Hello, everyone. Thank you for joining today. I'm joined here by Dr. Karen Courtney, and Dr. Courtney holds a background in health informatics and nursing. She held a National Library of Medicine predoctoral fellowship in health informatics research while competing for a PhD in nursing. She has a background in designing, conducting, and evaluating community-based health information technology products. These projects have community-dwelling individuals at the center and focus on meeting the self-identified needs and values of patients and family caregivers. Community-based participatory research pilot work funded by Clinical and Translational Science Institute, the Brand Corporation, with low resource older adults in Pittsburgh neighborhoods led to a 5-year agency for healthcare research and quality, a US funded study on community-based telehealth kiosks for health self-management by community-dwelling older adults. Her work with family caregivers and technology has been funded by the National Institute of Health, National Science Foundation, and Canadian Partnership Against Cancer. She's also the co-lead for a MSFHR Research Award, disseminating an action plan for gender, sex, and sexual orientation, terminology modernization in electronic health records. She's also a co-lead for MSFHR C2 Award to co-develop a digital health systems research program to support cultural safety and health equity for two-spirit, transgender, and non-binary patients in BC. She has been a wonderful mentor to both myself and the rest of the health informatics community. Thank you.
Oh, well, thank you, Cameron. I appreciate that. Okay, so I'm excited to see everybody here today. I know that we'll probably still have some folks dropping in because usually we have to get one Zoom call to get to the next. I welcome your questions as we go on. I am cognizant of the time, and I will leave time at the end because I do know that we have a whole room full of students here who may have some questions. But if there's a burning issue that comes up as we go along, feel free to go ahead and ask me questions as we go. I do have the chat, but sometimes I get a little distracted by what's on my slides. So feel free to use the chat, but I just might be a little slower in responding to that. And if you haven't used Zoom before, I will at some points be asking you questions. So you may want to locate those reaction things for being able to raise your hands. Those of you who are in the classroom, you get it easy. You just have to literally raise your hand. Okay. Sometimes the low-tech way is the easy way. All right, so my name is Karen Courtney, and I'm here at the School of Health Information Science. And as Cameron said, my background is both health informatics and nursing. Clinically, my background is in family practice and outpatient urology. So not neuro, but uro, other end. So some of my examples, as we talk about stuff, will come from my outpatient experiences. All right. So what I'm going to talk about today is really modernizing gender, sex, and sexual orientation, or what we call GSSO information within digital health systems, and kind of locating where we are in Canada when it comes to this modernization effort. All right, there we go. All right, and so I do want to begin by respectfully acknowledging the land on which I'm speaking, which is the traditional territory of the Lekwungen peoples, and specifically the Wasanich peoples, who have a historical and ongoing relationship with this land. And I recognize that the colonial injustices experienced by Indigenous peoples, many of which continue today and continue to affect their health and well-being. And so I know we're coming from many different places, and so I invite all of us here today to reflect on the privilege that they have of living, working, and playing in the territory from which you are joining this particular seminar. And I invite you to commit yourself with me to having an open heart and an open mind, to forging culturally safe spaces for and relationships with Indigenous peoples, including two-spirit people in Canadian healthcare, and making a meaningful contribution to reconciliation through our shared work. So what we're going to kind of look at today is to give you a background of who we are, what the problem space looks like, what's the current state of our digital health systems when it comes to gender, sex, and sexual orientation information, what are the consequences for when we get it wrong, what are some of the ethical issues that are enmeshed with this area, What about it? What is it to get it right? So kind of what's the broad picture of getting it right? And then starting to ask those critical questions for technical and clinical and work processes challenges, because it's going to cover all of those. And then, of course, we will kind of focus on where we are in Canada on these issues. And lastly, of course, I do have a list of resources. It's not comprehensive, but if you're interested in just getting started, these will get you, they'll get your feet wet, and you can link from the resources that I have here. Okay, so first of all, although I'm the one talking today, I want to acknowledge that this is actually the work of the UVic GSSO team, so Francis Law, who's here in HINF, myself, Erin DeVore, who's the chair in transgender studies, and then two of our HINF students, so Kelly, who I know is here, Kelly Davison, and Roz may or may not be with us today, but Roz Queen, who's one of our BSc students, and they have a long history with this team and the shared work that's happening. I also want to acknowledge that this work has been funded over many years through different sources. So CHR, the Michael Smith Foundation for Health Research has funded us in two different mechanisms. And so we're very grateful for that work that we've been able to do based on those funds. For those of you who are like, who are these people and what are they doing? I do have our website up at the top here. Hopefully you'll wait till after this talk before you Google it to get in there. But if you're curious, you can find some of what we're doing online in terms of recent papers and initiatives and things like that. All right, so yay, let's talk about sex and gender and sexual orientation. All right, so we're going to start off with some basic definitions, and many of you will be like, yeah, I get this. I've heard this, I know this. However, I start with these basic definitions because not everybody has. And if you looked at our digital health information systems, you wouldn't know that these definitions are out there sometimes. So let's have a shared set of definitions to begin with. So we'll talk about sex as a complex biological concept, but it includes anatomy, physiology, genes, and hormones. So many different components, which is important because when I give examples, sometimes the examples are targeting one of those areas, maybe not all of those areas. But sex is made up of a lot of different things, and it's a biological concept. Gender, on the other hand, is a complex psychological and sociocultural concept. And when it does have effects on sex characteristics, but gender is part of one's identity, and it may or may not reflect sex, and it may or may not be expressed. So it is not something that is always observable, right, other than to the person who it is their identity. And this is an important distinction to make. Sex and gender are two different concepts, although quite often, and well, we'll talk about digital health systems in a moment, quite often people think that they're one and the same, and they're not necessarily. And I will talk a little bit about sexual orientation today, but not much because most of our work is focused on sex and gender. So sexual orientation there's a lot of work to be done in there. And that work is still to come. So not so much focus today, but I do want to put it on the map because this is part of the same space that we talk about. So sexual orientation broadly describes how a person characterizes emotional and sexual attraction to others. And it has three different components. So one is a sexual identity. So that's how somebody self-identifies. It also includes how they perceive themselves as being part of a group or community or not. Sexual attraction is kind of how they describe what gender group or groups one is attracted to. And then sexual behavior refers to sex acts that one engages in, and it may be periodic, so it doesn't mean that it's consistent over time. But all three of these components are under that broader term of sexual orientation. But then it's important when we start talking about this work to note that sexual behavior, you can't assume sexual behavior based on the sexual orientation. They're not, sexual behavior and sexual orientation, it's not a one-to-one relationship. And that, I think, as we develop more work in this area, will become more important as we figure out what really needs to be in health records, or what information do we really need to capture on clients. Okay, but I want to put that out there so we know what the basic definitions are. Okay, another idea that I want to make sure we're aware of as we begin. We're all in health informatics. And I think once you see this, you're like, oh yeah, no, I get it. I know that. But sometimes when you're in the middle of an informatics challenge, we forget all the ways that we deal with data. And so I'll bring this up a couple different times when I talk about things. So when we think about data, obviously, we think about collection. We tend to think of that first. But then we think about storage. So how are we keeping it? How are we organizing it? How are we representing it? We talk about accessing data and information. How do we use it? How do we communicate or share it? We can talk about manipulation, right? So are there ways that we're using information to tell us other things, right? Are we changing the way we have data? So we talk about aggregation and rolling things up in the system. Those are forms of manipulation as well. We also talk about linkage, which is the idea that we are bringing different concepts together to help us understand both individual pieces better. So an example of this, and again, I'm coming out of a urology background, is, if you think about lab values for prostate specific antigen, that's a lab value, right? So you get that in a lab result. It would make sense to link that information to the surgical note for prostatectomy, right? Because you need to know the prostatectomy part in order to interpret the lab value part. And if you only go with a standard reference range, you potentially are going to have fatal consequences for that patient if you ignore the prostatectomy. So important things, we need to link different pieces of information for understanding. And if we fail to do that, we have some serious consequences. And then we also need to talk about reuse of data, which is something that we tend to not always think about firsthand. But we reuse data a lot, right? We may collect it for clinical purposes, but then we're checking out our policies and our outcomes and programs. And so we're reusing that data. We're looking at it again to say, are we doing everything that we can? Is the policy we put in place, is it effective? So we reuse data quite often. And then lastly, the thing that we hardly ever talk about because once we have it, we want it, is disposition. So is there an end to the data? Do we really keep it forever? And if we're not going to keep it forever, how are we disposing of it, and who needs to know, and who makes those decisions? We don't tend to talk about it, but it is part of that life cycle for information. All right, I just wanted to bring this up because as we look at the challenges of GSSO information and data, we have to think about all of these things. Okay, so we're now also at the point in which I want to make sure that I put a little warning message in here. And that we're going to talk about legacy systems. And sometimes legacy systems means literally what's down the hall from you right now. But these are the existing or past systems. And in order to discuss the problems with them, sometimes I'm going to have to talk about terms that are problematic. And so I'm just warning people up front, this is not where we want to go. It's unfortunately where we are or have been. So I just like to put that in there. I also do want to mention that the terms that I'm using today seem to have been acceptable when talking in community with folks, but this may not be true in 6 months, right? Language is evolving and things like that. So this is also something to keep in mind, not necessarily for the people who are live here today, but perhaps for people who are viewing this recording at some point down the road. The terms that have come up here may have evolved and changed. Okay, so let's talk about those legacy digital health systems. Now, I do have to say that most of the work when we have thought about digital health systems, we've thought about electronic health records. That's kind of where we've gone. But as we are moving forward, we need to think about all of the digital health systems that we interact with. So thinking about mobile health and thinking about virtual care, all of the things that we're doing, not just our traditional electronic health record. All right, but let's talk about our legacy systems, some of which you may be currently using. So sex, quite often it can be a solitary field. This is the only one you get. And so that's obviously problematic because sex and gender are two different concepts. And if we only have one field, what is it, right? We're busy enough in healthcare that we really don't want people staring at the screen going, I don't know what that field is. Is that supposed to be sex or is it supposed to be gender? I don't know. So solitary fields in themselves are a problem because you can't represent two different concepts with one field. Often it's a binary field. So male, female, which is also problematic. Because again, coming from a urology background, I can tell you, humans do not exist in the binary. We have more variation than a binary. And so when you've limited people to binary systems, we have a problem because there's a lot of people who do not fit within a binary system. And okay, so this next one, I want to put this out. It's sex within these systems is also often treated as a constant or an unchanging field. And so this is where I'm going to throw it now back to the students. So here's the question for you is, do you think that sex is unchanging? Is this actually a problem? What I'm going to do is I'm going to give a couple of statements. And if it makes sense for you, and this is where people in the room can raise their hands. If I say something that is for you, raise your hand and keep it up. And then we're going to see how many people this hits. Okay, so you ready? Everybody's found your reaction buttons? Here we go. This is a trial in action here. All right, so how many of you, raise your hands, know a postmenopausal woman? I'll raise my hand over here. Oh, wow, look at all these people raising their hands. Okay, great. All right, so keep your hands up. You guys have already been counted, so keep your hands up. Okay. All right. So how many of you know a child who has not reached puberty yet? Okay. All right. So we're over. Yeah, we're about right at half now. All right. So some other things. So how many of you know somebody who has hyper or hypothyroidism? Let's see if we can catch some more people that way. Yeah, everybody, you can keep your hands up. All right, a couple more people. How many people know somebody who's had breast cancer? All right, and and my last one is, so how many people know somebody who's had prostate cancer? All right, my very little picture of the classroom. There we go. Okay. All right, you guys can put your hands down now. But the reality is that for most of you who found the hands button, thank you very much. Yeah, so one of the things we do think of is we think of, oh, this is somebody, we think of this idea of constant or not constant sex as being a special case. And it's really not, right? Because we just saw in this room that you guys know a ton of people for whom that concept of sex, which involves things like structures and organs and genes and hormones, oh yeah, those change over time. Okay, so we can't necessarily assume that sex is a constant. And yet within a lot of our legacy systems, we treat it as a constant. Okay, so what else happens with sex in our digital health systems? Well, interestingly, it gets used for administrative purposes. And so usually I hear this a lot from folks that it gets used for identification. So basically matching somebody to their government issued photo ID. And they use the field of sex to make that match. What's one of the problems that happens with that? Well, for some folks, the way their systems are set up is because they're looking for ID matching, external non-health related sources can overwrite the data in the health record so that it matches. That's a huge problem. You know, I don't know about you, but I don't think the people down at motor vehicles really should be the experts on what somebody's sex is. But yet in some systems in this country, that's exactly what happens, because that particular data source gets priority. So this is a big issue, especially when you have the one field. So we can get overwritten by external, perhaps incorrect sources. The other thing is sometimes when you only have sex as a solitary field, sometimes people use that to generate the patient pronouns. And so again, that makes assumptions that sex and gender are the same thing, which we've already kind of defined. We've defined that as being different concepts. And so that also becomes problematic. And when you also have the solitary field, we really don't know what it is that you have. You know, maybe you have okay data. Maybe you don't have okay data. Maybe you have bad data. Maybe you have a mix of good and bad data. And it just means that you end up with something that is really just not usable. All right. So we can also talk about sex as it's used for clinical purposes. And so quite often, sex has been used as a shorthand for somebody's anatomy. And that covers things like structures, organs, hormones. It's just meant to be a shortcut. The problem is that when we use a shortcut like that, we've made some assumptions about what is either going to be present or not present. That's clinically relevant. And this includes structures, organs, and hormones. So in the example I just gave you, we don't expect a girl or a woman at age 8, age 28, and age 58 to be the same if we think about hormones, right? We're not even talking about injury, illness, disease, surgeries. We're just talking, we don't expect them to be hormonally the same across the lifespan. We expect changes. And yet the shorthand of using sex means that we miss that. That's a distinction clinically that we're not going to be able to make based on that particular field. So Simon is talking about those two uses of sex and gender data care in medicine. Yes, so sex and gender gets used quite differently. Are you there, Simon?
Yeah, sorry, Karen. I was thinking about leaving this to the end and bringing it up later.
Okay,
Thanks.
we'll do that. All right. So this is one of the issues that comes up with what's happening with sex in the legacy systems. And depending on the system that you have, you may have more or less of some of these components, right? So you might, maybe you have a sex and a gender field, but your sex field is still binary. So there's a lot of different variations on the issues that you might be encountering. All right, but let's talk now about gender in legacy systems. So often not represented, it's been smushed with sex. So a lot of times we don't even get it because there's that underlying assumption that sex and gender are the same thing when they're not. But if you get a gender field, one of the issues that sometimes come up is, again, this idea of binary. So man, woman. And I'm using man, woman specifically, although sometimes, which is also a problem, is sometimes you also get male, female put into gender, which sometimes also causes some confusion as people go, wait, it's a gender field, but it has male and female. Is it just the way it's written, or does that mean the wrong information's in the wrong place? Because it's not as clear. So sometimes that can be an issue. But binary, again, as I said, we have more variation in humans. And so binary designations don't really help us. Some gender fields will have more values. Some of the ones that we most commonly see is kind of this man, woman, non-binary, and the other. And it's in red. And we're going to talk about that because that's a problem. That word is a problem. Okay, so that takes us right into how can we get it wrong, right? So one of the things we can get it wrong is we can talk about this use of the word other. So why is other problematic? Well, it's problematic because it instinctively puts people into an us versus them. You're not part of our group, you're somebody else. Oh, another phrase that comes up is you're not in the normal group. These are all the really stigmatizing things that get said. And, you know, discrimination is a piece of that puzzle that happens. And so the use of the word other is generally highly offensive for folks. And so it's a word that even if you don't understand the why really, it's a word you should just put a star by and saying, do not use. Yes, very alienating because there is so much, we have variation in humans. And so other is not a useful concept for us. Something else you may see, depending on where you are in your legacy system, is you may also see something called sex assigned at birth. And so that's usually what somebody has tried to do in order to get at that idea of sex being used for administrative purposes and not necessarily for clinical purposes. But that's also problematic, which is also why it's in red. Because again, it's an assumption that somebody made an observation at birth and wrote it down on a piece of paper, and that observation, it's making the assumption that that observation is true. And so, in some senses, you're asking people to carry wrong information with them for the rest of their lives because somebody got it wrong at the beginning. And again, my urology experience will tell you, you can get it wrong at the very beginning. And the other piece is that, again, it's this idea of sex assigned at birth when you're really wanting to talk about administrative identity matching, which is really a different thing. And when I come to the end, we'll talk again about identity and really is sex part of that. Okay, so some other things that come up in this space is what's wrong with using assumed pronouns. And so, this is one of the things that we do need to ask people what the right pronouns are. Making assumptions about how people look or based on information that's in the system, it's insufficient and it causes people harm within the system. We'll get to that on the next slide. But assumed pronouns is a problem. We need to be asking people, and we need to ask everyone. I mean, this is part of it. It's not just it's not an assumption. And then lastly, this other piece, names are not part of sex and gender fields, but they go hand in hand with this issue, which is what is wrong with using the wrong name? This is one of the things that happens is that we have people who have names they want to be called, and yet it may be different from an administrative document. And we need to be able to put the right patient name, i.e. the preferred name, in front of people. So I try to explain this idea of what's wrong with calling somebody by the wrong name, thinking about it from the perspective, if you were about to go into surgery and you had your orthopedic surgeon mark on the wrong limb, and then they're wheeling you in to go under, it doesn't make you feel very confident in that orthopedic surgeon. And if you have a healthcare provider that calls you by the wrong name, it does not engender trust, right? You're thinking, do they know it's me? Are they thinking about another patient? Am I getting somebody else's medication? Am I getting somebody else's diagnosis? How do I know that they're going to get everything else right if they can't even figure out who I am? So pronouns and names are also very important, although they're not explicitly in a sex or gender field, but these issues tend to go hand in hand. So what are some of the consequences for when we get it wrong? And there is a citation at the end in the resources, so if you want to get more detail, you can. But we know that for folks who are sex or gender minorities, that they have lower rates of preventive care, they have higher rates of mortality, chronic disease, depression, suicide. They experience discrimination and stigma and negative healthcare experiences to a much greater degree than people who are cisgendered or heteronormative. And these experiences lead them to avoid the healthcare system. And so this is negative on an individual level, but it's negative on a societal level as well. And so there are big consequences when we get this wrong. Okay, so I'm going to tell you about some of the ethical issues that we run into. Some of them are, I think you have probably already figured out. From an informatics standpoint, we tend to look at the IMIA Code of Ethics because it's specific to health informatics. The general principles, I think you probably already have figured out, issues of autonomy and non-malfeasance, beneficence. One of the ones in the general principles that does come up that we sometimes don't put the connection to is the idea of integrity. Which is the responsibility to fulfill one's obligations to the best of one's ability. And if we think about the design of healthcare systems, and if we're designing systems that don't help healthcare providers get it right, that's an integrity issue, right? So we need to be thinking about how do we structure and how do we display information to help people get it right. Informatics is also interesting because we have a relationship with health. We have a relationship with information. And so one of the things to point out is that in our code of ethics, there are four principles that really speak to this issue. And so talking about information privacy and disposition, which is the idea that we have a fundamental right to privacy, and we have a right to control collection, storage, access, use, communication, manipulation, linkage, and disposition of data about ourselves. And it's interesting, I'm putting this up there because that whole lifespan comes right back to us. And it's part of our code of ethics and things that we have to pay attention to. And, you know, this is one of the challenges, because I think we would admit that even outside of the issue we have today that we're talking about, this idea about control is one that we probably have not really fully addressed. In the same line, we also look at openness, which is that people need to understand what information has been collected about them. Security, obviously the idea of protecting the information that we have. And then in terms of, well, I'll get to that when we talk about technical issues, but security is obviously an issue. And then access. So the idea that people who have these records are able to access their own records and correct them for accurateness. And this is also, I think, an area where we have a lot of work to do. All right, and for those of you who are also in leadership positions, there's also the Code of Ethics from the Canadian College of Health Leaders. And the 4 different domains that they have are definitely affected by this particular issue. So just pretty quickly, for an individual level, thinking about promoting equity, diversity, inclusivity, and intersectionality, and looking at confidentiality of information. From an organizational perspective, thinking about quality and safe health services, thinking about how the public is involved in health and health services, and thinking about continuity of care and health of the community. When we think about those consequences when we get it wrong, this is where it plays into. So healthcare leaders, people who are making decisions about our systems and how we practice, there's a role in here. For making progress on modernizing GSSO. And then also lastly, talking about this idea of promoting a healthy work environment. And when I talk about work processes, we'll come back and revisit that one. Again, professionally, the idea of having cultural humility. And then again, the idea that we are also responsive to the community that we serve. So thinking about how is the community involved within the digital health system? You know, how are you engaging people, patients and their families? How do you engage them in the process of looking at what's in those records and how people control them? All right, so we've talked about getting it wrong. Let's talk about where we want to go to get it right. So in terms of thinking about where we want to be, this is thinking broadly right now, this is where we seem to be going. Is so we want to get to digital health systems where gender is not conflated with sex. That's pretty much a consensus. But then we also want to start to talk about using patient-specific inventories to direct preventive care, to help interpret diagnostic testing, and also to do treatment planning. So we'll talk about these types of inventories in a moment. And then lastly, getting back to that tough idea of control, thinking about linkage and sharing and reuse of data and who gets to control that piece. Those are going to be some tough questions for us. But those are the things that we're looking at in terms of how do we modernize, how do we make it right? One of the things, you know, I would say that when we look at GSSO information and information practices, it's like looking at that HIMSS maturity model. People are in all different places in terms of what their systems have or don't have. And so for some folks, one of the things, they're not ready to do organ or hormone inventories yet. So they may be looking at this interim step called sex for clinical use. This kind of goes under the caveat of warning because this is there's not a universal consensus on this idea, but it is an idea that's being proposed as an interim step. How do you get from where we are to where we want to be? And so the idea with using sex for clinical use, it's kind of like sex assigned at birth. It's a very clunky way, and it doesn't deal with the inherent problem, which is that sex for clinical use still relies on that shorthand, and it still makes assumptions that if I understand sex, I inherently make assumptions about structures, organs, and hormones that may or may not be present. So it doesn't get me to the level of specificity that I could get if I actually had those inventories. one of the pieces that does come up in SECS for clinical use is that they are putting in fields called specified, which is the idea that you could perhaps then link specific information to screening or tests or results. So remember, this is an interim step. So it's not giving you the detailed information like you would get in an inventory, but it is providing more than you currently have in terms of being able to make some of those linkages. All right. So in terms of thinking a little more specifically, we have kind of the broad picture of how to get it right. But when we start to think about the technical aspects, this is truly an informatics challenge because it involves both the technical, it involves the clinical, it involves work processes throughout the organization. On the technical level, I mean, the easy answer is, let's just buy a new one that works. Right. But easy is not always the most feasible, right? So, and we do know that there's ongoing work in terms of procurement for systems. So you could procure a new system, but vendors are also still working on updating those systems. So it's hard to say, oh, I'll just go out and buy the thing that has the newest one. One of the things to consider, and again, this gets at the idea of your maturity level in your system, do you have legacy systems that really will not link to newer versions of standards? So if the standard gets updated, do you have perhaps a module or a decision support piece that even though the EHR gets updated, it just doesn't recognize the newest version of HL7 or SNOMED or LOINC or whatever piece it needs to tie into? That's something that you may have to consider. So it may be that you're looking for maybe not overall buying a whole overall system, but you might be looking for specific functions to find something new. You may also be looking at, okay, we're not at the point where we can buy something. So let's talk about how we can customize what we do have. And so thinking and talking with your vendor about, can you separate sex and gender into different fields? If you have existing sex and gender fields, can you get them to accommodate new values or new options as you need them? And thinking about still keeping in mind interoperability between your systems. You have to consider whether or not sex for clinical use would be a reasonable interim step for your organization. Or is your organization at the point where, yeah, you could do something like an anatomy or physiology inventory, something that has both structure and organs and hormones in order to be very specific and be patient-centered? Are you at that level where you could actually integrate that piece? Again, thinking across that life course of our information, you're going to need to walk GSSO data through your system. Simple questions like, how do we prevent our data from being overwritten by somebody else's external source? How are we using this? What is the primary use for the data? Should we be collecting it? Where does it get collected? Thinking about the reuse. Is it being used in embedded decision support systems like a dose calculator? Is it being used in written communications with your clients or in reports? So is it pulling in pronouns and gender? Is it part of your performance improvement initiatives? Again, you have to think about all the ways that we interact with data in our systems. And then lastly, that tricky question about control. How do we involve our clients in control of their own data? And this is the point where I'm going to raise that challenge question. I suspect I already know the answer, but I'm going to challenge you to think about the answer about whether or not there are more accurate ways to match client identity for payment purposes other than sex. You may not really have another alternative, but I'm going to ask you to think about whether or not there's something else that could be feasible, because then it gets you out of the whole administrative sex stuff. You can take that out of the equation. And so I encourage you to think about that in the long run. In terms of clinically, starting to do a slightly deeper dive, are your systems supporting respectful interactions, right? So if you look at the display that's in front of a clinician, is the client's preferred name the most prominent name visible? Some systems, it's not. You have an administrative name that pops up and preferred name is somewhere down on the quarter in like a 10-point font. That is not supporting clinicians to get it right. The name in front should be the name to be used. Are appropriate pronouns easy to find? So if somebody's trying to do the right thing, can they find it easily? You know, are your reports being populated with the preferred name and the pronouns? You know, is appropriate anatomical and physiological data being tied to your screening, diagnostic tests, and the results? You know, so do you have accurate information when somebody shows up in radiology and needs to have an X-ray or have another type of radiological exam? Do they know where to put the lead apron? It's an important question from a clinical perspective. And yet quite often, no, we're asking an X-ray tech to make a call on where that should go. So thinking about that, I've talked about examples about post-proctectomy patients and prostate-specific antigens, linking surgery and lab results. Those are important distinctions. So there's lots of things that we need to be able to tie that into. You know, how are your clients involved in the collection, use, reuse, and sharing of their data? And this is probably a fundamental kind of organizational culture question. You know, how are you involving them and who gets to make those decisions? You know, if you have a patient-facing system like a patient portal, how is sex and gender information being displayed to that particular client? Are they able to control that piece of it if they want to share their record? Are clients being asked to update their clinical information? You know, we assume that the provider is the only one collecting the data, and yet our clients are patients. They're experts in terms of knowing who they are. So thinking about, okay, so how are we involving folks in this? And can clients control the types of data that are shared in particular contexts? And so, for example, an example that comes up here is thinking about adolescents. And so can adolescents control who sees certain portions of their record? That's an example that's very broad, but yet fits right in with this. We also need to think about the work processes, which are a little broader than clinical. So thinking about whether or not you've updated work processes and workflows. You know, have you changed the physical space so that you can have private and non-intrusive data collection in this area? You know, have you updated your policies and procedures manual to reflect how people are supposed to be doing their jobs? Have you trained all of the staff so that they're asking all of the clients for sex and gender information when it's appropriate? Have you had sex and gender information explicitly considered in your privacy and information security policies? You know, do you handle that data differently than, say, other data in the system? You know, have training and supportive materials been provided to clinicians and staff for handling clients who react negatively to information requests? I mean, this is part of it, right? We know that not everybody's going to be supportive. And this is that healthy work environment. So how do I help people get it right? Okay, so I did promise you, and we've got a few seconds to go through what's happening in Canada. So we have an action plan for where we want to see this work go in Canada. The REACH project, we talked to folks over the course of a year, specifically about terminology and about policy and about specific settings. And I'll show you some of the things that they came up with. We have had some progress with SNOMED CT, the Canadian version. And it looks like we might have a couple other countries that are interested in some of the things that we've done in gender identity. So that may go beyond the Canadian edition to become international edition. And then recently we just finished part of the gender harmony ballot for HL7 and FIRE. So we are seeing movement in those areas as well, and I'll share some of that. So the action plan, there's a citation for the resource at the end, so you can go right out and read all of it. But this is really where we want to go in Canada, looking at GSSO data information, both from the standards perspective and then also how we handle that. In terms of the REACH grant, we did make a lot of progress in terms of thinking about terminology. Some of the SNOMED CT work came out of that work group. We've also looked at some of the other ways and where the work still needs to be done. And so I'll show you that on the next space. Whoops, I guess it's a little further on under future work. We do have some consensus on how to culturally safe policies for GSSO data collection. And I put these out there because this is something, if you're thinking about that work process piece and thinking about the change management that's going to have to happen, these are some of the things that people across the country have kind of agreed on in terms of policies, so that it's universal, everybody gets asked, that we have an informed consent piece in terms of thinking about disclosure and sharing. We talk about updating the data. It's not constant, right? So how do we update? We talk about building confidentiality into the process itself. Talk about staff training and how do we ask for this information? Who's asking for it? And then I think the last piece is is it actually relevant? Are we collecting information that we're actually going to use? Because if we're not using it, why are we collecting it? I did promise a sneak peek. There's actually quite a bit that happened out there, but there were some proposed changes for SNOMED CT for the Canadian edition that got submitted, and I just actually pulled one of those out. But this work, and I'll show you where it's posted, but we have been making progress in this area. We just finished the balloting for HL7 and fire based on the gender harmony project that was going on. The Sex and Gender Working Group at Canada Health InfoWay was one of the groups that provided a lot of feedback on the very specific data elements that they were looking for. And sex for clinical use was a hot topic among our group. There were lots of comments made. I've only pulled out one that was kind of like a summary of verbal discussions from the group. But it gets to some of the things that I've talked about already, which is the idea that sex for clinical use in itself still has problems within it about the assumptions, and that perhaps we want to think bigger and thinking about parameters for clinical use and thinking about organ inventories and other types of inventories to actually do what we want to do, which is to have patient-specific information for preventive care, for screening, for diagnostic testing, and for treatment planning. I have mentioned the Sex and Gender Working Group. We're an active group. We meet every month on the 4th Tuesday. So if you want, we're meeting next week. You do have to register in advance to get the link to the actual meeting. I have that here, but you can also go out to Canada Health InfoWay and search for us. We're a lively group that represents clinicians and people with lived experience and standards experts and health informaticians and policymakers. And we talk about sex and gender in digital health systems. And so we talk about how do we make it right and where are we and where are the examples. In the last month, we were talking to a vendor who showed us what they were working on and had the group provide discussion and comments on what they're working. And the sex for clinical use had a lot of discussion. They're coming back again next month, or well, I guess next week actually, and we're going to talk about the privacy implications, which gets at that control issue I was talking about. And so that's going to be up for discussion. Prior to that, we had somebody talk about how the change management strategies they were using to actually implement some of these changes. So if you're interested in this work and you're trying to think, ooh, I'd like to do this, but I don't know where to start. There's people out there in the Sex and Gender Working Group who would love to have a conversation and love to be able to support you moving forward. There's a lot of work to do. Obviously, we didn't really touch on sexual orientation. That's a whole open field for us to deal with. We really need more use cases. We need to work on those inventories because that's where we want to go. We need to talk more about implementation and how to get it right. And we need to continue to work on those standards and getting them updated. As I said, the REACH group did come up with some very specific things. I will have it here in the slides. So those of you can take a look at the slide deck, or you can just pause this if you're looking at a recording and take a look at some of the very specific things people were talking about. What could we do in the future? I'm going to flip it now to the resources, and I'm going to turn it back over to the group and open it up for questions. We still have some time for questions. And so I'll try and get things coming in the chat or hands that get raised. But I'll leave the resources up so it'll be running in the background.